panel discussions are innovative. It's a great benefit for anyone who takes the time to attend this meeting.
And there was a very practical handling of how to use imaging, how to make interpretation.
Also, it touches various topics, both on the culinary and structural side. Very insightful, exchanging scientific data and results of trials.
And several live cases have been performed to show complex, innovative procedures. Several workshops were welcome to all of you, and it has been our practice to start rolling on time, so we are about a minute late, but I am very grateful to all of you who have turned up in time over here. And the history of CVT goes back from 2005. That's where we started doing this conference, and with everybody's indulgence, and this event has grown, and we are very happy to have such stalwarts from all over the world who have joined us to share their experience. And amongst them is one of my mentors, Gary Rubin. I trained with him in University of Alabama at Birmingham, and I would say he has shaped my life, and whatever I've been able to do till now has been after he changed my thought process over there. I went as a very raw person, thought I knew everything, but how to look at life is a very different perspective. So Gary, thank you very much for that. We are getting rolling with the first session so that we can keep the whole program available for discussions and thoughts from everybody else. The first session is the gateway to the chip arena. So we are talking about the basics like access, transpedal access, transseptal puncture technique. So let me invite our moderators, Dr. D.S. Chadda, Dr. Amit Chaurasia, and can I also request Gary to please come and join us to moderate. Dr. P.K. Hazra, the chairperson. Dr. Henny Reggie is there, I'm seeing there. Dr. R.D. Yadav, Dr. Saurabh Malhotra, Dr. Ranjan Modi, Dr. Vikas Goyal. Gary, please. Dr. Deepak Ameta, Dilip Tiwari, Manish Kapoor, Vaibhav Bandel, Ashish Tiwari, Harshvardhan. Dr. Harshvardhan, please join us there. Thank you very much. We'll get rolling with the first speaker, and that's going to be Dr. Amrish Sathwik. So he's the Sachin Tendulkar of the CVT India 2025. Amrish is a very accomplished endovascular interventionist. So he's going to talk today about transpedal access technique. So these are all tricky things. Not everybody is very comfortable doing these things. So Amrish, if you are all set, then we can get rolling.
Good morning. I'm delighted to be here. Thank you very much, Dr. Mathur, for inviting me. I'm going to be speaking about transpedal access for lower extremity vascular interventions. Now, this is the spectacle that you're likely to encounter and stumble upon in most vascular cath labs that are doing complex interventions infrainguinally. You can see that there's a sheath in the groin and there's a sheath in the foot. And increasingly, vascular interventionists are using pedal access for difficult lesions. Now, the only thing that one needs to reckon early on is that pedal access is only for chronic limb-threatening ischemia. It's not for claudicants, because the pedal vessels are the runoff or the outflow vessels of the foot. So you're playing with the final terminal destination of the vasculature of the foot, so you'll have to be careful. Any trashing or damage to the outflow tract, and a claudicant is converted into limb-threatening ischemia. Now, pedal access is primarily a rescue intervention. The CTO crossing failure rate is about 20 to 50% based on the experience of the operator. So primarily, pedal access is for failed antegrade access. It's the plan B. But also, sometimes it could be the opening gambit. It's how you approach a patient primarily. When would that be? Such an intervention has been christened TAMI, which is quite a mouthful if you're going to say the whole thing. TAMI is not just pedal access, it is completing the intervention from the foot. Now, why do you want to do that? Let's take this example. If the aortic bifurcation is not particularly friendly, let's say you're treating distal disease, the tibials, in normal circumstances, the image on the left, you'll see that you need 4 changes of vectors to reach the contralateral groin. In the case on the right-hand side, if it's an unfriendly aortic bifurcation, you'll need 9 changes of vectors to reach the contralateral groin, not just the target vessels. So in such cases, you might want to do TAMI. But also other indications such as this, morbid obesity, hostile groin, if there's an abdominal pannus, if the patient is unable to lay supine for very long, and particularly in cases of post-aortobiofemoral grafts to treat distal disease, which we do all the time. Also, you'll get better catheter support while crossing CTOs with retrograde access. You get better pushability due to the short distance from the access point. On the right-hand side, you're seeing that you can virtually see the better pushability with catheter support. Now, we're in a position to understand cap morphology in CTOs better. Fadi Saab and others from the Michigan group have developed a classification and a crossing algorithm for these. You'll see that in type 1, you'll almost always be able to cross antegrade if the cap looks like that. Type 2 or 3, you may be able to cross antegrade, but you may require pedal access. And type 4, I think you'll have to consider primary pedal access, sometimes even TAMI. Sometimes you might need bidirectional wrangling to cross the lesion and use some of these techniques and some jugaad. So let's come down to the fundamentals and the specifics. You'll need a micropuncture set, you need to instill vasodilators, and you'll need to target an ACT of roughly about 250 to 300, closer to 300 because these vessels are really tiny and fibrin develops in these vessels really quickly. These are 2 of the sets that we commonly use. The one on the left is a 4 French micropuncture sheath and set, and the other one is a 2.93 French set. This is what the 3 French set looks like. It's excellent if you just wish to cross the lesion, but if you wish to do anything more, then you might be well advised to settle for the 4 French one. The puncture could be ultrasound guided or fluoroscopy guided. In fluoroscopy, you may decide to do it angiographically guided or just calcium guided. But remember, fluoroscopy may have parallax issues. This is what the anterior tibial artery looks like. It is mildly compressible, but you can see the paired tibial veins are completely compressible. If you encounter something like this instead in the tibiopedal vessels, this is a white stop sign. There are no clear layers, there's acoustic shadowing, and the vessel is non-compressible. This isn't a good vessel for retrograde puncture. This is not going to end well. And this is what I mean by direct fluoroscopy guided or calcium guided puncture. You can see the tracks of calcium, and you can see here we're sticking in a needle right into the vessel at the ankle based on calcium. This is the anterior tibial being punctured under fluoroscopy guidance. We've injected contrast from above, and we're about to introduce the wire here. This is what it looks like in angiography. The needle has been positioned, and the contrast is coming in. The needle is almost about to make contact with the anterior tibial, and we've hit the anterior tibial. We're taking an angiogram from the needle, and then we've passed a wire in. You can track the wire on ultrasound, you can and on angiography, and you can do this coincidentally. This is the wire being tracked all in the tibials as you ascend up the leg. Now, if you see something like this, these are gaps in calcium, this could be a problem. This is due to degeneration or negative remodeling. Basically, there is no artery there, and these vessels are highly susceptible to rupture. So if you see something like this, you'll have to be wary. And there is always the problem of the rolling artery. If the artery rolls under your fingers, what you could do is stick in 2 needles on either side, ultrasound guided, to fix the artery, and then put in a needle right into the artery. That will solve the rolling artery problem. The other tip is to stay distal. The risk of compartment syndrome due to bleeding complications isn't there if you're distal. The compartments get bigger the more proximal you get, and you might encounter that if there is bleeding. A lot of people go sheathless, so do we, but if you're going to do just more than crossing a lesion, always put in a sheath. It's more protective to the artery. This is a little maneuver at the time of puncture that makes all the difference. Plantar flex for the anterior tibial and dorsiflex for the posterior tibial. I'm going to show you 2 quick cases. This was an anterior tibial artery occlusion. We weren't able to cross this in an antegrade fashion, so we puncture the anterior tibial at the ankle. This is the wire going up. This is the Rubicon as the support catheter. We've managed to cross the lesion and enter the anterior tibial. This is the wire being swallowed up by a catheter that is waiting there. And this is the exit strategy. The Rubicon has been removed, and simultaneously we're inflating a balloon to make sure that the puncture point is sealed. Balloon angioplasty after that. And this is the reconstructed anterior tibial. And this is the runoff to the foot. That's a beautiful anterior tibial and dorsalis pedis and a partly forming plantar arch. Another case, no anterior tibial, no posterior tibial, but there is at the tail end of the posterior tibial forming the plantar arch. There's a peroneal. We weren't able to connect the peroneal to the posterior tibial antegrade. We do a needle puncture of the calcium. I'm done in 10 seconds. This is the wire ascending up. And we're now drilling through the vessel, getting into the peroneal from the posterior tibial at the ankle. This is a balloon angioplasty of the occluded segment, and we've managed to connect the peroneal to the posterior tibial, and that's a beautiful plantar arch that you can see. Thank you very much.
That's a very concise presentation. This is, of course, there's a lot to learn. Could you tell us about the wires that you're using? And
yeah, the micropuncture sets are 014, 018 compatible. Our preferred wires are hydrophilic, either a V14. Sometimes we might decide to use dedicated crossing wires like the Command Extra Strength, or something with a tip load that is not very high, because you want the wire to knuckle a bit as you're drilling through the vessel. You don't want very, very hard CTO crossing wires. But usually, in most cases, we're able to get through using hydrophilic wires, 014.
Comments from the chair, Dr. Hazra? Or? Yeah.
Very, very much. I put it in my slide. The first thing you do is to inject vasodilators, because these are 2 millimeter, sometimes 1.5 millimeter arteries. So very, very prone to spasm. The first thing you do after putting in the sheath is give vasodilators, and a higher ACT than what you'd do for a femoral sheath.
So I remember, Gary, you used to conduct an endovascular course when we were at UAB with you. So any comments on this?
No, an excellent presentation. Very, very fine work. Simply would mention there are other options if you're dealing with popliteal SFA disease. You can't manage antegrade, and the popliteal approach is also one which you can get very effective with, and also now direct puncture of the upper popliteal, even above the knee, which is another way to approach this under angiographic control. It's hard to get ultrasound deep there, but you can manage that. So, but I think the pedal access has revolutionized for critical limb ischemia.
Absolutely.
And I think it's very
I'll reserve the popliteal for claudicants, because one wouldn't want to fool around in the tibials and claudicants. But one word of advice, definitely use lead gloves when you're doing pedal access, because you are going to irradiate your hands quite significantly.
Thank you very much. A big hand for Amrish. This was a very good beginning to our sessions today. And let me invite our next speaker, that is Dr. Samir Dani. So Samir is a very close friend, and he's one of the senior-most cardiologists working in Ahmedabad. and most of the senior Indian politicians have been under his care. So Samir, you're going to talk about transseptal puncture. So there's a lot of interest in mitral valve interventions, TMVRs and mitral clips, and of course BMV was what we used to do a lot in our country. So Samir is going to talk about the tips and tricks for transseptal puncture. Over to you. So I would request the audience to please step forward. We have some AI-enabled mics for the front rows, and when you ask your question, you'll be showing up on the screen also. And for the people who are sitting behind, we have mics on the aisles. Please get interactive. We would like your questions also to come.
Yeah, good morning, Atul, and thank you for inviting me over here. It's always a privilege and honor to be here amongst such an august audience and chairpersons. So I'll begin very quickly. Transseptal puncture is not a new thing for most of us. We have been doing lots of PTMC over last 35 years, and doing a transseptal puncture on fluoroscopy guidance is a very easy thing for most of the interventional cardiologists in India. But now the indications for transseptal access have widened, much unlike before. So it is necessary to revisit the technique of transseptal puncture, and it is very important to know. Mind you, transseptal puncture was first time described by Ross and Braunwald et al. Way back in 1959. That was the first ever transseptal puncture technique described. And then it has evolved, especially nowadays with imaging and newer interventions. And this is the timeline of these evolving indications for transseptal access or puncture or catheterization. And contemporary transseptal transcatheter interventions are many, as you can see, not only limited to PTMC, but percutaneous mitral valve repair like MitraClip or Pascal or transcatheter mitral valve replacement. And we also use it for left atrial appendage occlusion, atrial fibrillation ablation, PFO closures, and sometimes in ASD closures, LV access for various reasons, and LA pressure measurement, which was the indication for which Ross described the technique. It is extremely important to revisit the anatomy of the interatrial septum because in mitral stenosis with a bulging interatrial septum, high LA pressure, it is a different ballgame to puncture the septum. And here, when you are doing mitral valve interventions for mitral regurgitation, the things can be different. Same thing goes for LA appendage occlusion. So it is very important to get your anatomy and relationship of the various structures surrounding the fossa ovalis, and that is how we decide where to puncture the fossa ovalis or where to puncture the interatrial septum based on the type of intervention that you intend to do. The common toolkit is, of course, broken brow needle, which has been there in existence in so many years, but now it comes in different shapes, and it also comes in extra sharp version, which is helpful for patients who have had previous surgery, scars, or calcified or very thick septums. And you have various transseptal sheets of various curves and steerable sheets as well. Standard transseptal broken brow needle has a standard curve of 50 degree, which has a less reach, and it's easier to adjust the target puncture site as far as height is concerned, but larger curve is needed when you are dealing with large atria. Fluoroscopic based puncture is the standard technique which all of us know, O32 wire in SVC, pigtail in non-coronary cusp of the aorta, Mullins sheath or dilator in SVC, broken brow needle inside the dilator, needle marker at 3 o'clock while in SVC, then you pull back while rotating to 4. There are 2 jumps. One, you come from SVC to RA, which jumps the aortic knob, and then limbus to fossa. And then you move to 5 o'clock position while still pulling back and then engage the fossa ovalis. You may take AP and lateral view to puncture, and there are many experts who take RAO or LAO view as well. But it is very important to image the needle in at least 2 projections. And you must have your radiological anatomy straightened out in your mind that in LAO or RAO view or lateral view, which structure is where. Once you are familiar with these anatomical landmarks and once you are sure that you are on the septum, then you puncture. And it is very important to use contrast injection, not only aspiration of the blood, because LA would have oxygenated blood, but even aorta would have that. And aortic perforation has been one of the complications which has been described. This is typical AP view where you engage the needle below the pigtail in the aorta and slightly lateral to the spine, and then reconfirm it in lateral or LAO view, or you may confirm in RAO view and then puncture. Shaping of the TSP needle has been described based on RA size, and you can give secondary curve to the needle and then puncture the septum. It is easier to engage the septum that way. Now, there are challenges, obvious challenges with conventional transseptal needle when you are performing other interventions than PTMC. There can be excessive tenting in a compliant septum. You can require a significant force to puncture with unpredictable needle movements. There is risk of perforation of left atrium. If your needle jumps in, you may slip on the bulge and may lead to inaccurate puncture. And inaccurate puncture in PTMC may lead to little extra procedure time. You may be able to slip into the mitral valve, but it may lead to complete abandonment of the procedure or re-puncturing the septum if you are performing some other interventions. So it is very important to do a precise puncture, and that may not be possible with fluoroscopy. Side by side, I would also mention the other newer techniques or newer equipments to do the transseptal puncture, especially the radiofrequency needle and safe sept wire, which are used with minimal force to produce the puncture, especially the Baylis Versa-Cross radiofrequency wire goes in with a radiofrequency ablation, creating a small puncture in the interatrial septum with minimal force. You can also use broken brow needle with radiofrequency energy or electrical energy by connecting it to electrode, ECG electrode. Fallacy of fluoroscopy-based puncture, as I said, as I have already alluded to, it lacks precision, and precision is something which you really want when you are doing procedures other than PTMC. So TE-based puncture is one of the most important techniques as far as any transmitral interventions are concerned. Bicable view is the most important view. You see SVC and IVC properly to see supero-inferior septum. Pull back the TSP system rotate with a rotating sheath from 3 to 6 o'clock position to reach fossa and create tenting. And then most importantly, your person on TE, the echocardiographer, has to show you the needle using X-plane or changing the TE angle from 90, 110 to 40 degrees to determine whether you are anterior or posterior. You take 4-chamber view to see the height from the AV valve annulus. Here, high and low punctures are described in relation to the mitral valve, and superior and inferior are described in relation to superior vena cava and inferior vena cava. And then you puncture if you are satisfied. It is very safe and precise, and that helps you in doing your intervention. Biplane TE for TSP is well described, and troubleshooting, most important, procedure-specific puncture site. Remember the jargon, because your echocardiographer may be using some different terminology than what you understand. So anterior is low and posterior is high as far as TE is concerned. Sometimes you may have to use 3D to understand how to navigate. You have to understand modality-dependent terminology, as I already said, and then puncture either using needle or RF needle or electrocautery or coronary wire stiff tip. People have described ICE for TSP, and people have taken help of CT scan, especially in difficult anatomy, to determine the site, ideal site for transseptal puncture. So what are the sites for transseptal puncture? Superopist posterior, superior posterior for mitra clip, especially when there is functional mitral regurgitation or A1P1 leak. Inferior and posterior for some other types of mitral clip, and of course PTMC, mitral valve in valve, or valve in ring, or LA appendage occlusion. Anterior and superior for transseptal PFO occluder, or especially EP, when you may have to make 2 punctures for 2 catheters if you are doing AF ablation. Middle for atrial septostomy, one of the oldest indications, and inferior anterior for some forms of direct annuloplasty. The desired puncture site for mitral clip, I'll just wind up. Okay. So rationale is very easy to understand. It is important to be aligned to the mitral valve axis or LA appendage so that you can reach there easily. As far as AF ablation is concerned, you have to be aligned to entry for the pulmonary vein. And mitral clip puncture differs significantly from PTMC puncture in puncture site and the primary goal, and typical height away from the mitral valve is more important so that bulky assembly can go in easily. In challenging anatomy, you may have to resort to modification in these techniques. The stepwise algorithm is like this: needle crossable. No, then you use some other alternative techniques as described. If yes, then you decide about dilator and sheath, and then successful TSP is completed, and then you go on to your intervention. Complications are standard. Perforation is the most dreaded one. To summarize, ideal location of transseptal puncture varies depending on your intended intervention, and it is very important to select proper site for successful intervention. And CT planning and TE and ICE are very useful tools for this. In fact, without TE, it is almost impossible to do most of the mitral interventions. Thank you.
That's a very excellent presentation. Actually, there's so much we can talk about transseptal puncture. We'll take one quick comment. Anybody? Yeah, Dr. Haney.
Thank you. This was very, very important, and I know how difficult it was to give it in such a short time. I think the message you gave us, which is very, very clear, is to be slow, is to be patient, and not to rush into transseptal puncture. You can restart and restart and restart, but don't cause a tamponade. It was a really comprehensive presentation. Thank you.
Thank you.
Thank you very much, Samir. A big hand for you. So let's move to the next presentation. That's going to be Dr. Amit Chaurasia. And the other burning topic these days is the large bore access. And so many structural interventions and large bore access is a very major concern. Gary, you have been involved in development of one of these devices. A quick comment before we load his presentation.
Yes, I would simply say that good access is essential to a very safe closure, whether you're using suture techniques or using a closure device like the MANTA device. So I look forward to hearing this presentation. Yes, I was the guy who decided we needed the MANTA. So yes, that was my device.
So we have a live case tomorrow where we are going to use the MANTA device. should we take you to the live center? Okay, there you go, Amit.
Good morning, everyone. Thank you for this opportunity, and special thanks. I would like to thank Dr. Atul Mathur for this wonderful opportunity. So my presentation is on the large bore femoral access and closure. And everyone would agree that this is the bottleneck of all TAVI or any kind of large bore intervention. So these are the common approaches: the transfemoral approach, the subclavian approach, carotid approach, or you can do a direct aortic approach. I will be just concentrating on the femoral approach because everything is not possible in a short time. Also, now a lot of devices are available. We started with ProStar, which had 4 needles that would come out, and invariably it had some 30% failure rate because the needle would be embedded in the skin, and then at the end we would end up dissecting the skin and taking out the needles. Finally, it would be the surgeon who would bail us out in most of the time. That was way back in 2012-13. Then came ProGlide, and ProGlide changed the whole scenario. But ProStar, you needed a single ProStar to actually do the large bore access. With ProGlide, you needed 2, because those days we had devices that were above 18 French. So we needed 2 ProGlides, and we would put it in 10 and 12 o'clock position. Now, over a period of time, as the device's size decreased, we have slowly moved on from 2 ProGlides to 1 ProGlide and 1 AngioSeal. Now, it is very important to understand when you are using an AngioSeal, you should also keep in mind that it takes time for the whole device to dissolve. So it takes around 3 months' time. So if you are using AngioSeal on one side, that is 1 ProGlide and 1 AngioSeal, while doing TAVI, the second side you should close either with a ProGlide or just do a manual compression to close it. Now, when you decide to do a large bore closure, you should understand that you should scan the whole segment. And when you scan the whole segment, look at the artery, whether there is a calcification or not, whether you feel any kind of fibrotic segment or not, and how tortuous is the artery. Your main vessel should be the one which is less tortuous, has less calcification, and less fibrotic segment. The other segment you should keep for a therapeutic, for a diagnostic purpose. Now, when you look at this artery, this is straight artery. When I look at this, there is hardly any calcification. There is some calcification over here. The bifurcation is way down on the right side. So this would be the ideal for a large bore access. If you see on the other side, you see there is a small branch coming out over here. And if you are going to take a puncture, you may end up in this branch. So it is better to avoid this side for a large bore access. This side would be an ideal. Now, I would also show, if you are taking this side puncture, then you should also be careful that this is a posterior calcium. In a posterior calcium, you will still be able to put a ProGlide. But if this calcification is on the anterior surface, then ProGlide won't be possible. So when you are taking, you should keep all these things in mind. The second thing is you should know the diameter of the artery and the diameter of the device that you are going to use. So if the ratio is more than 1.1, then you should keep in mind that you have a large chance that it is going to perforate or something like that. And you should be very careful about that. Now, it is not you should scan the whole segment for the size of the artery and not rely on a single place measurement. These are the very hostile aortas. You see, there are calcium on the anterior surface. The puncture site is going to be very high. There is high tortuosity. And if you want to actually go in this femoral, then I would suggest that the left side will be better than the right side. But still, you should keep in mind that the ProGlide could fail in this kind of cases. And if you are going to do a large bore access in this, then don't use a like normal PTFE wire. Use a hard wire, something like Amplaza super stiff wire or that sort. This is why I tell that you should scan the whole artery. If you see there is a calcification up here, the size of the artery dips in this segment, so this may not be a good artery for even 14 French segments. The second thing is you scan with the ultrasound where the calcium is and how bad the calcium is. If the calcium is on the anterior surface, using the ultrasound, whether you'll be able to take the puncture or not. So let me just start how we started. We started with a fluoro-guided puncture, and that is how we used to do. We used to just cross over, take a puncture, take an injection, then put a wire as a guide, and take a puncture. Subsequently, some people started doing this, putting a pigtail and then using a pigtail as a guide for the puncture. But today, ultrasound guided is the standard of care, and this is how we do it. What we do is we take the ultrasound probe, and then you scan the whole artery. You see the distance, that is the distance of puncture. And after you see there, you also look at the calcification, where the calcification is. You slowly scroll down, as you see over here, to see where the bifurcation is. You can see the bifurcation is way down over there. And then again, come up, you make a longitudinal segment over there. See the relationship of the longitudinal segment to the head of the femur, that is just behind, whether any kind of calcification is there. Avoid the calcified area, and again come to make a circular view. Now you have a fairly good idea where you want to take the puncture. So that's the segment where we are going to take the puncture. So bear with me, I don't know. Okay. So once you have identified the segment, then just make a circular segment, take some local or Xylocat to infuse, and you take the needle. Under guidance, you infuse till the top. So this way you are making sure that the local anesthesia is given adequately and in the right place. You can see the injection over there, the separation over here. And then you take the needle. So sometimes the needle is not visible. What you can do in that case is just scrape up the top portion of the needle, and that makes the needle visible under ultrasound. After you do this, you remove the needle, you give some small nick on the either side, and extend the puncture site. Now it is very necessary to do that, because if you don't do that, all the seats have a top portion, and that goes and sticks to the skin. You put in the seat after that, and once you do that, you take the ProGlide. So you keep on inserting the ProGlide till you see the wire comes out from those two white markers up there. And once you get that, you slowly keep going in till you see sprouts of blood coming up from the top portion over here. Remove the wire as it reaches the skin level. You should maintain the angle of 60 degrees so that you don't have ProGlide failure. Most of the ProGlide failure is because you don't maintain that angle. 45 to 60 degrees essential while you do that. Then you open the first segment, you pull back till the blood stops, plunge in the plunger. That is, you are sending in the needle, and then when you pull back, the needle actually forms a kind of knot inside. I'll be showing the procedure, what happens in a meanwhile. Then you remove the sutures. You take arteries of forceps and just put the sutures on the either side.
अभी टाइम हो गया.
Just give me some time. It's essential because more than talking, if you see it, it's much easier. And once you do that, your ProGlide is in place. So there are a few things that you should understand while you are doing the ProGlide. So once you see the sprouts of blood, when you pull back, that when you open the knob, this knob is opened on the either side. And then the needle goes in. Now, when you cut open, and then you need to push it inside so that this pedal gets a space to open up. If you don't do that, then sometimes the pedal breaks, and then you are stuck. You don't know what to do about it. Then you will have to cut open, and there are ways by which you can do the procedure. And this is how you complete the procedure. What you do is you slowly take the blue segment, not the white thread on the suture, and then pull out. You pull the blue segment, and once this is out, then what you do is slowly you pull first the blue segment, take the knot pusher, push the blue segment, and then
Amit, we are running short of time.
let's skip through this one.
I think we can stop here and have some
I
discussion.
think this is done. Thank you for this. This was a
Yeah, the video is quite long, but
I think
it's very clearly shown, very well made videogram. So I think that's a big hand for Dr. Amit. And this was a very nice presentation. So can I invite Dr. P.K. Hazra now for, again, something related to this access and ultrasound guided
Actually,
vascular access. Some things have been shown.
Yeah.
But you can tell us what are the highlights.
Okay, so my day is already made. When I met Atul Mathur in the morning in the corridor, and I saw Professor Antonio Colombo sitting here. Thank you, Dr. Colombo, for coming here. So today's talk is on ultrasound-guided vascular access. Vascular access doesn't mean only arterial. Nowadays, the venous axis is also very important. And the life, Atul Mathur, life can become much easier if you take help of technique and technology. And when I started my journey with intervention in cardiology, I was like this. I'm sure everybody was like this when they started doing femoral puncture. Now the life has become much easier with mentorship and training. Sterility is important, and once you maintain that sterility, you can have this access for cheap, large bore access for TAVR, EVAR, MCS, venous access for TMV or mitral clip, tricuspid clip, leadless pacemaker, and ECMO. So what are the objectives? You prevent hand radiation, calcium-free zone stick, single attempt success, prevents retroperitoneal bleed and death, pseudoaneurysm formation, fistula prevention, mortality reduction, vascular device implantation with lot of safety, sheath kinking, imbricated access sheath, save money and short hospital stay. It's challenging when you have obese, small BSA, frailty, especially on oral anticoagulant, NOACT and DAPT. Repeat procedure, like you had one procedure in the past, now we are having another procedure. Vast history of local complications like pseudoaneurysm, surgical repair. There are a lot of trials which say there is no difference between vascular access versus fluoroscopic access. No sign of difference in this trial, but when it comes to no cost, no contrast, no hand fluoro, I'll go for it. So Altacolor trial was negative, and this is the man who presented universal trial. It was a negative trial or neutral trial. And what he has shown that in ultrasound guided and non-ultrasound guided, if you use a device closer like AngioShield, there is numerically smaller complications. The bark bleeding was less numerically without any p-value for interactions. If you go from pure RCT primary endpoint to subgroup analysis, if it is done by Atul Mathur and done by a fellow like me, the complication will be much higher if it is done by a fellow. And if you are using vascular closure, the complication will definitely come down. So ultrasound access expertise, and vascular closure. If you go for the meta-analysis tells a different thing because it comes from the real-world data, real-world study. It does reduce the major bleeding and vascular complications. And you know how to do it. You should check it with angiogram, small puncture needle. And you can see nowadays with beautiful Philips ultrasound machine, the portable machine, this kind of movement inside the femoral arteries. Sometimes, you can encounter this ghost. This is a hernial sac. And as I said, once you grow with your technique and expertise, the complication comes down whether you use ultrasound or not ultrasound. Obese patient definitely is a challenge like this. You cannot stick to this kind of anatomy. You have to lift the obese part, abdomen up. And imbricated sheath, I have mentioned, is a real problem. It will bleed. You can upsize, but it is real challenging when you have this kind of kinking of the sheath. Trajectory you have to change. You have to make some adjustment in obese patients. And this angle doesn't work in same subject. It may work in the same weight patients, BMI, but it may not work with a different BMI or higher BMI. So we have to change the equation according to the obesity. And in obese people, if you have complications, very challenging and the mortality goes up. Sometimes you can use intravascular ultrasound. Like nowadays, you have 8 French TAVR system from Seagull. Your entry may be 8 French, but it cannot be done through the radial route because it expands inside your iliac artery. So these iliacs can be assessed by intravascular ultrasound along with your CT scan. So we are all looking for this fictional sweet zone, but in reality, it may not be possible unless you have some knowledge about this sweet zone on intravascular ultrasound. So friends, I think it's very important to understand the anatomy, avoid inferior epigastric artery puncture, and please learn ultrasound from your varicosity vein interventions, your routine femoral 6-French femoral access, or large bore access like MICRA, AVR, TMVR, or TAVR. So here is one trick for venous access because I do a lot of leadless pacemaker and I have encountered huge complications like the fistula formation. So if you have venous access, nowadays you use 2732 French device for your clip, etc., etc. So once you puncture the vein with ultrasound, gradually pull the sheath and check the pressure on the hemodynamics. If you have gone anterior and posterior, suddenly the pressure jumps and you have to take another puncture. It's very simple, but it prevents the complications. Friends, if you are playing golf, from table tennis to golf, sometimes if the hole is just nearby, you just don't need any putter. But many times it is a very difficult and tortuous path. You have to use some kind of technology. Thank you very much.
Thank you very much for being on time. And this session was really very educative because these are basics and where we create all complications. So I'll thank all the speakers, the moderators, and the chairpersons, and the experts for this session. And we move forward to the next very exciting session. There'll be a lot of interaction. I would like all of you to participate. Thank you very much.